Okay. This is testicular, testicular tumor part 4 and the last part of the testicular tumor. We will come to the primary chemotherapy for stage 2 and stage 3 germ cell cancers. We will start by chemotherapy known as platinum cisplatin. And as you see, we have this dose of 10 milligram and also we have a dose of 60 milligram. It's accordingly you can estimate the dose for your patient. This is a chemical structure is very clear. This is a platinum with 2 chlor and also we have 2 ammonia molecule in this structure. Platinum cisplatin is the most effective agent against germ cell tumors. However, multiple agent regimens containing cisplatins are more effective than a single agents. Primary chemotherapy refer to the first line regimen that is administered to treat the cancer. Salvage chemotherapy refer to the regimen that is delivered after failure of primary. So after failure of primary, we go to the salvage chemotherapy. It is known as second or third line. This is known as salvage chemotherapy. The standard first line chemotherapy regimens for stage 2, stage 3 germ cell cancer is either bleomycins, etoposide, and cisplatin is known as PIP, or etoposide or cisplatin is known as IP. So this is etoposide and cisplatin is known as IP. All right. So in good risk patients, bleomycin, etoposide, and cisplatin 3-time cycle is as effective as etoposide and cisplatin 4-time cycle. So this is in good risk patients. In men with sufficient renal function, carboplatin should not be substituted for cisplatin in good risk patient because it results in lower complete remission rate. Intermediate and poor risk patients should receive PIP 4-time cycles. VIB 4-time or etoposide and isofosfamides and cisplatin, this is known as VIB, can be utilized for intermediate and poor risk patients who have a contraindication to bleomycin. We'll use VIB or etoposide and ifosfamides and cisplatin 4 cycles for patients have contraindication to bleomycin. And VIB, it is VB16 etoposides and ifosfamides with Mensa and cisplatin. The Mensa is decrease the risk of cancer formation, bladder cancer formation. Cisplatin is cross-linked DNA. Those limiting toxicity lead to nephrotoxic chemotherapy, and other side effects include neurotoxicity, hearing loss, diminished cardiac function, nausea, vomiting. As I mentioned, in patients with metastatic cancer and sufficient renal function, carboplatin should not be substituted for cisplatin in good risk patients because it results in lower risk remission rate. In cases when the renal function must be preserved, carboplatin dose limiting toxicity is lead to myelosuppressions and may be substituted for cisplatin dose limiting toxicity, which is the toxicity is nephrotoxicity. So carboplatin lead to myelosuppression and cisplatin lead to nephrotoxicity. We come to the bleomycin. Anti-tumor antibiotic that bind to and break the DNA. Side effect, pneumonitis, pulmonary fibrosis, nail and skin caries. Bleomycin-induced pulmonary toxicity increase the risk of respiratory complication during surgery. This preoperative pulmonary complication can be reduced by aggressive monitoring, avoiding overhydration, preventional preferential use of colloids, and judges use of crystalloids, keeping fraction of spare oxygen less than 25%, fraction of spare oxygen less by 0.25 or 25%. All right, so the relative contraindication for bleomycin are reduced pulmonary function tests like COPD or renal insufficiency or age more than 50 years old. This is a relative contraindication for this bleomycin. Pulmonary impaired pulmonary function, COPD, for example, renal insufficiency, and age more than 50 is considered a relative contraindication for bleomycin. We come to the etoposide, and etoposide is abbreviated in VB16, and this is the chemical structure of etoposide, and as you see here is the dose of etoposide 5 milligram. Etoposide VB16 is alkylating agents covalently bind to the DNA. So it is bind to DNA by covalent bonds. So those limiting toxicity myelosuppression, etoposide as well as other the chemotherapy that speak about it previously is known as carboplatin is also lead to myelosuppression. Here we have etoposide. It will lead to also toxicity limiting due to myelosuppression. Another thing is mucositis. And other side effects include vomiting, alopecia, dose-related leukemia, 0.8% risk with mean latency period of 2 to 4 years. We come to the carboplatin, which is actually, as you see here, this is the structure of carboplatin, is hexo and hexo chemical structure plus this fourth angle structure with 2 ammonia platinum. So it's the same with the structure of platinum and another structure with 2 oxygen. This is known as carboplatin, and for testicular cancer, usually we use the dose of 450 milligram per 45 ml. This is for testicular cancer. We will use carboplatin, and 1 or 2 cycle of carboplatin treatment option for stage 1A or 1P pure seminoma. Those limiting toxicity myelosuppression. Other side effects of carboplatin include nausea, vomiting, and neuropathy. We come to sulfide chemotherapy. Sulfide chemotherapy is indicated for men who progress during primary chemotherapy or who relapse after primary chemotherapy. Conventional dose sulfide chemotherapy include VIB, that means Vilpan, known as vinblastine, and ivosfamide with Mensa, and cisplatin. This is known as VIB. Vilpan, this is vinblastine, and ivosfamide with Mensa and cisplatin. And Taxol or paclitaxel or ivosfamide with Mensa and cisplatin, this is known TIP. 50% of sulfide achieve complete response, but only 25% sustain remission. High-dose sulfide chemotherapy and autolog bone marrow transplant. High-dose chemotherapy kills bone marrow, thus an autolog bone marrow transplant is given after HDC to reconstitute the marrow. Durable remissions are achieved in 10 to 20% of the patient. Treatment-related mortality is as high as 5 to 10%. We'll come to the post-chemotherapy residual erythroperitoneal mass. Residual erythroperitoneal mass rarely contain teratoma after primary chemotherapy for seminoma, but 40% contain teratoma after primary chemotherapy for non-seminoma. A residual mass is more likely to contain malignancy after sulfide chemotherapy than after primary chemotherapy. After primary chemotherapy, when the patient has do a good response to chemotherapy and normalization of the tumor marker, retroperitoneal surgery may be indicated based on the size of the residual retroperitoneal mass. And then seminoma or mixed germ cell tumor after primary chemotherapy for stage 2 or stage 3 non-seminoma, residual mass less than 1 centimeter is unlikely to contain teratoma or malignancy. Only 9% of this patient recur, with only 4% recurring in the retroperitoneal node. A residual mass more than 1 centimeter size has significant risk of containing either cancer or teratoma. Therefore, the patients with residual more than 1 centimeter in size undergo full templed retroperitoneal lymph node dissection with resection of the residual mass. Pure seminoma after primary chemotherapy for stage 2, stage 3 seminoma, a residual mass less than 3 centimeters is unlikely to contain malignancy, where the residual mass 3 centimeters contain cancer in 30 to 50% of the case. So less than 3% in pure seminoma not contain malignancy, but this is residual. But if more than if 3 centimeters or more, this is 30 to 50% contain cancer. Patient with residual mass more than 3 centimeters in size should be undergo PET CT scan. This is for pure seminoma. If the mass is metabolically active, perform biopsy or excision of residual mass. Retroperitoneal lymph node dissection is not done because chemotherapy for seminoma induce a desmoplastic reaction that make dissection difficult and substantially increase the morbidity of template retroperitoneal lymph node dissection. After salvage chemotherapy, when the patient has good response to chemotherapy and normalization of tumor marker, residual mass resection with retroperitoneal lymph node dissection for non-seminoma, and mixed tumor is indicated for any residual retroperitoneal mass, regardless of the tumor types or the size of residual mass. Because residual mass in these settings have a significant risk of containing cancer, 50%, or teratoma, 40%. This is the orchidectomy pathology. This is type of chemotherapy type. And here we have composition, both chemotherapy residual retroperitoneal mass. Is it germ cell malignancy? Is it pure teratoma? Is it necrosis or fibrosis? So pure seminoma, it is primary, as well as non-seminoma is also the chemotherapy type is primary. And any germ cell tumor salvage chemotherapy, here we have primary that the germ cell malignancy 10 to 20%, and pure teratoma is non-common in specimen of orchidectomy. Pure seminoma is rare, and necrosis or fibrosis 80 to 90% in the patient with retroperitoneal lymph node. Composition of both chemotherapy residual and retroperitoneal lymph node usually appear as necrosis and fibrosis in patient with histopathology of orchidectomy show pure seminoma. Non-seminoma or mixed germ cell tumors, it is actually the chemotherapy is primary type, and also it is less than 10% germ cell and pure teratoma, 40 to 50% pure teratoma, no viable germ cell tumor, but it's pure teratoma. And the necrosis or fibrosis is the same percent as pure teratoma for mixed non-seminoma or germ cell tumor is 40 to 50% in the retroperitoneal mass. Post chemotherapy, when we remove this residual, usually appear as necrosis or fibrosis. Any germ cell tumor we underwent salvage, the salvage chemotherapy, 50% germ cell tumor, 40% is pure teratoma, and this is all these four retroperitoneal residual mass usually appear as a germ cell 50%, and also 40% for teratoma, 10% for necrosis and fibrosis. Remember that overall malignancy occurring 10 to 20% here, 10 to 20% of residual mass. When stratified by size, malignancy occurs 30 to 50% more than 3 centimeters, but it is rare in mass less than 3 or equal 3 centimeters. A follow-up depends on the type of the testis tumor and the mode of the therapy delivered. Follow-up protocol for the stage 1 patient undergo surveillance and can be found in the lesions here For a germ cell tumor, follow-up usually consistent of regularly performed serum tumor marker imaging and physical examinations. The remaining testing should be always examined routinely because the accumulative risk of malignancy in the remaining testicle is 2 to 5% by age of 15 after orchidal follow-up. Physical examination should include examination of the testicles by physician and by patient self-exam. After surveillance for stage 1 germ cell cancer, recurrence after 5 years occur in less than or equal 1% of patients. For this reason, obtaining serum marker and imaging beyond 5 years of follow-up are typically done only as clinically indicated. If recurrence occurs, the patient should be re-staged and treated. Patients with testicular cancer should be monitored for signs and symptoms of hypogonadism. If hypogonadism is suspected, measure monitoring serum testosterone level and luteinizing hormone. For patients whose treated include radiation and or chemotherapy, advise these patients that they have increased risk of cardiovascular disease. They are 1.5 to 2 times more likely to develop cardiovascular disease compared to those who did not receive chemotherapy or radiation. They should be monitored by primary care physician so that modified risk factors that contribute to cardiovascular disease can identify and treat. Advise these patients that they have an increased risk of secondary malignancies. They are 2 times more likely to develop another malignancy compared to those who did not receive chemotherapy or radiation. They should be monitored by primary care physician and have appropriate cancer screening. This is survival for stage 1, 2A, 2B, 2C, 3. This is IGCCCG risk status, and this seminoma, non-seminoma 5-year survival. For stage 1, this is no risk. The status is no risk, and here it is seminoma 5-year survival more 98%. Also, non-seminoma is the same percent. And for stage 2A, 2B, no risk status by IGCCG, and it is also more than 95% as well as non-seminoma. This is a 5-year survival. And here we have also stage 2C and 3 have good, intermediate, and poor. The good that is 86% for seminoma and 92% for non-seminoma. Intermediate, that's 72% for seminoma and 80% for non-seminoma. And poor, this is for seminoma, no any poor prognosis, 5-year survival, and 5-year survival for non-seminoma is 48%. Seminoma does not have poor risk category, as we mentioned. This is the stage 2C and or 3, have good, intermediate, and poor. This 5-year survivor progression. And as you see here, good at 82. This is 82. This is 5-year survival, 5 years progression-free survival. This is 82%, and this is 89%, and here intermediate 67%, and this 75%. And it is poor for non-seminoma. It is 41%. Seminoma does not have a poor risk category. This is the evaluation of suspected testicular cancer. Suspected testicular cancer by scrotal ultrasound is Doppler. Normal finding and normal, no further evaluation. It is suspicion finding, then we will go to do alpha-fetoprotein, quantitative BHCG, LDH, CBC, and liver function creatinine. And then we go to the ultrasound. Ultrasound is intermediate for normal ultrasound intratesticular mass and normal serum tumor marker, or ultrasound that show that the tumor confined intratesticular mass with or without abnormal serum tumor marker. The ultrasound, repeat scrotal ultrasound after 6 to 8 months if it is show intratesticular mass and normal tumor marker after 6 to 8 weeks after previous ultrasound. Then that the tumor marker is positive or negative, and we have intertesticular mass, we'll go to offer spare banking testicle prosthesis for man. This is after we do consider multi-parametric MRI of the testicles with gadolinium. Also, we'll do same that the testis confined testicular mass. We'll go for spare banking and prosthesis if needed for men with reproductive age. The patient wish to preserve gonadal function, accept the risk of the testis, preserve ovations, and any of the following condition present: tumor in solitary testicles, synchronous bilateral testicle mass. The contrast is likely poor functioning with minimal contribution to fertility and testosterone testis atrophy. A normal serum tumor marker mass less than 2 centimeters in size. Ultrasound intermediate for malignancies. These masses are unlikely to be benign. If this is available, this risk factor is available, or this risk to testis preservations is available, then we will go testis preserving excision of the mass through the inguinal incision and intraoperative pathology assessment. Malignant, we will do radical orchidectomy. Tumor is completely excised by testis pairing. Yes, multiple biopsies at epislateral normal to check the germ cell in situ. Germ cell in situ is absent. See that we'll come to the excision of the testicular mass, and germ cell is present. Treatment option of the germ cell is actually radical inguinal orchidectomy. Is this evaluation of suspected testicular mass. If there is no this risk factor is not available, radical inguinal orchidectomy from the beginning with the possible placement of the testicular prosthesis. And was the biopsy of the contralateral testis performed? Yes, that's germ cell absent, present, and then we come again to this. And it is not present, then we will go to treatment after excision. This evaluation of suspected testicular cancer is again the same what we discussed previously according to this. All the initial management after testicular mass, we discussed all this previously. This is no tumor, no germ cell, or benign, no further evaluation. Lymphoma, refer for medical oncology, systemic therapy, territorial leading cell tumor, CT scan, abdominal pelvis with contrast, chest X-ray. If chest X-ray is abnormal, we go to CT chest. When clinically indicated, bone scan, surveillance if no metastasis. Germ cell, we check the tumor markers, all the tumor markers, and CT abdominal chest imaging for 1A or 1B pure seminoma. Chest X-ray, if chest X-ray abnormal, we go to CT chest with contrast. For non-seminoma mixed germ cell, stage 1S, 2, 3, chest CT with contrast, IV contrast. When clinically indicated, brain MRI or bone scan. If serum tumor marker normal and imaging inclusive for metastasis, repeat imaging 4 to 8 weeks. Pure seminoma normal, alpha-fetoprotein, non-seminoma mixed germ cell tumor or elevated alpha-fetoprotein. This somatic malignancy present or not present, we will go to discuss management accordingly. Both chemotherapy management for stage 2, stage 3 pure seminoma, all this we discussed it in the previous post. Chemotherapy for stage 2, stage 3 pure seminoma, we will do serum CT chest, abdomen, and pelvis with IV contrast, tumor marker shrink, marker normal and no residual mass less than 3 centimeters. Observe relapse salvage chemotherapy. Tumor shrink, marker normal, residual more than 3 centimeters. PET scan negative, PET scan positive. PET scan negative, we will go to observation. PET scan positive, we will go to resect for or biopsy for residual mass. Malignancy, we will do salvage chemotherapy. Pure teratoma, we'll observe. If there is a relapse, we will do salvage chemotherapy. Necrosis or fibrosis, 80 to 90%, observe. If relapse, we'll do salvage chemotherapy. And if the tumor grow or marker rising, we'll do directly salvage chemotherapy. Initial treatment for non-seminoma mixed germ cell tumor in adult. we have stage 1A, stage 1B. All this is actually, as I mentioned, we'll manage it by this two BIP or IP. BIP 2 cycle or IP 4 cycle for the non-seminoma stage 1A or stage 1P. If stage 2A or stage 2B, we will go directly to a retroperitoneal lymph node surveillance, retroperitoneal lymph node dissection. And last but not least, we will go to chemotherapy. This is post-chemotherapy management, stage 2, and serine and seminal germ cell tumor. We mentioned that we will do salvage chemotherapy. Thank you very much. This is the end of the lecture.